A very good day to you all, ladies and gentlemen. Welcome to the Cardio Live interview of the INSHLT 2019. I am Dr. Ahlawat, Senior Consultant Cardiac Surgeon from National Heart Institute, and I welcome Dr. A. Nagesh, Senior Consultant Cardiac Surgeon and Heart Transplant Surgeon from the Care Hospital, Hyderabad. Welcome.
Hi, morning.
We're going to talk about Ecmo, its cannulation strategies, and how is it going to affect the outcome. Ecmo, as you know, has evolved considerably over the time, but let us start for the sake of all of us from the basic. What is Ecmo and how does it, and what are its indications basically? How has it evolved?
Now, primarily Ecmo is extracorporeal membrane circulation. The need for it arose because there are in clinical practice you come across a lot of conditions where the heart is good but the oxygenation of the lungs is improper, and in those stages simple ventilatory management can't take care of the hypoxia or hypoxemia which happens. Now, because of this we have two different types of an Ecmo. One is VV Ecmo and VA Ecmo. Now, the VV Ecmo is veno-venous and the VA Ecmo is the veno-arterial. Now, the indications are quite different for each of them, and the VV Ecmo is mainly for where the heart function is proper. You do not have to consider, you are not worried about the function of the heart, but there is a lack of oxygenation in the lungs. So, mainly in ARDS, and it has come in vogue now more because of those H1N1 influenza and all, where the lung is incapable or is not capable enough of delivering the amount of oxygen which you want. So, you are trying to get it done by some artificial methods. Now, the VA Ecmo is mainly more for where the heart is affected, either the left ventricle or the right ventricle depending on whichever one is affected. We have various types of Ecmos for that. Now, the VA Ecmo is mainly used in patients with acute myocarditis where the patient has developed cardiomyopathy, and in patients on whom resuscitation is being done in an acute emergency where CPR is being done and you want to take the patient out, or in post cardiac bypass surgeries where you are unable to wean the patient off bypass. So, in those cases you want to give the heart and the lungs some rest where they recover from this injury, and then you can tide over the crisis.
So, basically there are two types of Ecmo runs, which is veno-venous or veno-arterial run.
Yeah.
And if a patient requires Ecmo institution, which is the ideal place would you say should it be done into?
Now, Ecmo is again of two types, the cannulation sites. The cannulation is either central or peripheral. Nowadays, the central cannulation is easier to institute because you have to do a sternotomy.
And we all are familiar with it.
We are all familiar with it. So, the point to remember is institution of a central cannulation is preferable only if you are in an emergency. In an emergency, you can't search for the peripheral cannulas and all. So, it is always open to go on bypass, and from the same cannulas or by attaching a graft or something, you can cannulate and go for a central Ecmo. The other area where you can get a central Ecmo done or is preferable is if you are planning on putting the patient on some VAD support. So, the same cannulas will help and the same cannulations will help, albeit with some new modifications and all, but the process remains the same. So, if you consider these two conditions, then it is better to go for a central Ecmo.
And also in complex congenital surgery.
In complex congenital surgery.
It is better to take the patient.
Exactly, because you do not know what is underneath or what is inside.
Yeah.
But peripheral cannulation is the preferred mode nowadays because the patient can be ambulatory, and you can take care of a lot of disadvantages which are there with the central cannulation, vis-a-vis chance of infection, keeping the chest open, not ambulating the patient and all these things. So, these things can be taken care of with a peripheral Ecmo.
Yeah. So, what is this that two types of or basically three types, central and peripheral cannulation, and it can be done either as a continuation of a cardiotomy procedure in the
Yeah.
theatre or in ICU in cases where the chest is not open.
Exactly.
Like in the cases where, as you said, respiratory cases, VV ECMO runs,
Yeah.
like that, or postpartum cardiotomy,
Yeah.
myocarditis, so on. Regarding the cannulation strategy, what would you suggest? Like open Seldinger or open Seldinger, which would you prefer and why?
Most of the times peripheral cannulation is usually done on an elective basis. You are not doing it in an emergency. So remember, one point to remember, if you are in an emergency setting, go for a central one. You do not search for a peripheral one. So once you are doing a peripheral one, we usually they are usually done under ultrasound guided or TE guided, as well as a lot of institutions support it to be done under fluoroscopy for the positioning of the cannulas and all. Because in peripheral cannulation, the most important and point is the drainage. The drainage has to be perfect for the ECMO to work. So it all depends on where the cannula is being inserted and where is the tip of the cannula, and these are the things which are more important in terms of peripheral cannulation. So the most commonly used sites which we use are, one is femoral and axillary. For the return, it's always the IJV is preferred, the internal jugular, the drainage cannula, and some
In a venous.
in a veno-venous,
Yeah.
the IJV is preferred, as well as the femoral is done. A femoral venous cannula can also be inserted. And if it's a veno-arterial, then an IJV is preferable as the drainage cannula. And for the arterial returns, it can either be the femoral artery, the axillary artery, but in children, it's preferably put in the carotids. The advantage of an auxiliary one is, now each and every cannulation site has got its own pros.
Yeah, I will come to that. My point was this, that would you prefer as a open technique of peripheral cannulation or Seldinger or open Seldinger?
No, Seldinger technique is always good, because hemostasis is there. You don't need to worry about displacement of the cannulas, because the skin itself is fixing the cannula in its position. You don't need to worry about that. But sometimes the length of the diameter of the vessel which you want to cannulate is small. In those cases, you may have to put in a free graft and then take it out through the skin and then do it.
That 8 millimeter side arm graft, kidney graft.
So if that graft has to be done, then it has to be an open one. So that's the whole criteria.
Yeah. And what are the challenges with different type of cannulation sites you were mentioning? Like in carotid, in children there is very high risk of stroke.
Yeah.
Can you please tell us about other sites also?
Yeah. Now the best and the safest site is the IJV, where you don't find much of any risk. The only problem is, if the IJV is small, then you may have to dilate it and then do it. But the only requirement, or the basic requirement, is you require a good anesthetist who understands what is happening, preferably done under fluoroscopy as well as TE guidance. Now coming to the femoral is always good. Now if you consider a femoral for both veno-venous, then it's ideal that it should be done in both the separate legs, but then the patient is not ambulatory. So that takes away the ambulation part out of the equation. And the problem with femoral cannulation is the tip it all depends on the drainage site. Now the tip of the cannula has to be at just at least 2 centimeters below the IVC. So then only the proper drainage can happen. So
at the level of hepatic vein.
At the level of the hepatic veins. The axillary problem is but the disadvantage of a femoral cannulation, arterial cannulation, is you are providing a retrograde flow. It's not an antegrade flow, it's a retrograde flow.
Yeah.
But that advantage comes with the axillary way. The axillary artery can be cannulated and it will provide antegrade flow to the heart, but the disadvantage of an axillary is it's an open procedure. You can't do it percutaneously, and bleeding and hemostasis is one of the disadvantages of an axillary one.
If you were to cannulate femoral artery, where would you keep the tip of the cannula?
The tip of the cannula has to be, it's usually, the length of the cannula is small. So basically it's usually near the internal iliac.
Brachiocephalic and arch.
Yeah.
And are the cannulas different for arterial and venous cannulation?
Yeah, all the cannulas are different because in a arterial cannulation you require smaller French diameters.
As arteries are smaller in size.
Exactly. And the length of the cannula is also small because you don't need to pass it up to the arch. It's basically, it's usually delivered somewhere near the, it ends near somewhere near the external iliac.
Major blood vessel.
Major blood
like
vessels.
Aorta or
Yeah.
iliac.
And in a venous, the system is you should put as big a cannula as you can because you want to drain the heart. You, so as big cannulation as possible depending on the size of the vessel. Whereas in arterial, you are just want to, it's a normal standard cannula depending on the size of the vessel.
And these all cannulas are usually wire reinforced.
All of them are wire reinforced. So,
and they have to be there for long duration, so they usually have been coated or bio.
Exactly.
And and they are available in various sizes. I believe they are available from 8 French to 24
they are available from
French.
8 French, 10 French is the smallest one of
Venous.
No, in venous they are all big ones.
Yeah, venous, arterial is from 8 to 21.
Arterial is 8 to 21 depending
venous
on
is from
different
10 to
companies and
22,
all. Yeah.
And can you tell me something about what is the problem with the recirculation and the watershed issues with this type of cannulation?
Now in peripheral VA cannulation, the problem, the recirculation or the watershed happens in 2 areas. One is in VV, let us consider VV first. Now if you are having a dual cannulation where one cannula is from the femoral vein, the other cannula is from the IJV. Now if the IJV cannula or the femoral cannula, and now the ideal positioning is the femoral cannula, venous cannula has to be at least 2 centimeters below the inferior vena cava, veins in the hepatic veins.
Yeah.
And the tip of the cannula in the IJV should be near the SVC RA junction.
Yes.
Now if either of this positioning is wrong, then there is a recirculation of the blood. So to now
that means the oxygenated blood is
getting mixed with the
and is
deoxygenated
withdrawn
blood.
before circulating in the body.
Exactly, to the lungs. So the whole purpose and the idea of to eliminate hypoxemia is lost because of this.
Yeah.
So proper positioning is very important. So that's one area where the recirculation happens. Now the other more serious recirculation happens, or the watershed movement which you say happens in the VA type of a cannulation, where the heart is ejecting blood and the venous, the arterial cannula from the femoral is providing blood supply in a retrograde fashion. Now the antegrade and the retrograde meet at the point, at some particular point, it's usually somewhere near the descending aorta. So if it sometimes, but that position can't be determined specifically because it all depends on how well the LV is ejecting. Now if the LV is ejecting well, then the watershed movement will be somewhere down. If the LV is not ejecting well, then the retrograde flow is more, so the watershed movement will be somewhere higher up. So depending on that, you have to adjust the various ventilatory settings as well as use of inotrops and all.
Flow also.
Yeah. The problem in this watershed movement is if the LV is ejecting, it is and the lungs are bad, it is ejecting hypoxemic blood out, and here you are getting oxygenated blood. So the upper periphery is being getting deoxygenated blood and the lower extremities are getting oxygenated blood. So that's why there is a syndrome called a north-south syndrome. The upper one,
oxygenation.
Yeah, the differential oxygenation part. So now this can be tackled only if you, by following the trace, the arterial trace in the monitor. So this is something which the perfusionist has to look into, and the surgeon as well as the team of the Ecmo team should be knowing. If you are not having a trace, arterial trace, it means that the LV and diastolic pressures are quite high and oxygenation is not happening properly. So you always have to ensure arterial trace in the Ecmo monitor. So, if the Ecmo monitor shows arterial trace, it means the Ecmo is working well.
Yeah. And are there any combined cannulas available for veno-venous Ecmo?
Yeah, now to take out this two equations of one is of this recirculation part, the other one is to make the patient ambulatory. Nowadays dual cannulas are coming, dual chambers. So, there is a single cannula, but it has got dual ports, sometimes it has got 3 ports. Now, the company is Avalon, and I think there are a couple
is it available in India?
Yeah, it is available.
Okay.
And even the other one, the Chelsmade cannulas are also available. Now, it has got 3 ports. The proximal port, the distal port lies somewhere near the IVC. The proximal port is as the SVC. The middle port is in alignment with the tricuspid valve, so that the oxygenated blood goes from there.
Yeah.
So, you are taking care of the recirculation which we were talking about, and the patient is ambulatory because it's from the IJV.
Yeah. And how would you suggest the cannulas to be decided? What are the criteria which one should keep in mind before choosing the right cannula for the right person?
Now, whenever you are going for a VV Ecmo, drainage is the main concern. So, you should always choose a cannula which is big, so that the drainage is proper. So, the aim is to get at least to drain at least 80% out, so that it will help you. And while choosing an arterial cannula, it all depends on the size, because it's all ultimately the size related of the cannula, of the organ, of the vessel in which you are putting it. So, but in a percutaneous technique, you can do all these things by dilating and putting in bigger sizes cannulas.
So, basically the cannula which provides a maximal flow with the least damage to the bloods should be chosen.
Exactly.
And what are the possible cannula complications you must have encountered, and how to tackle them?
The most common, the learner one, is in a VV, it is mainly the positioning. A lot of times we just push in and there is this recirculation phenomena. So, once this recirculation phenomena happens, you will always know by the saturations and all those things, and so that can be tackled. The biggest learning point where while doing a VA, peripheral VA, is in terms of ease. A lot of times you want to put the cannula in the, like for a normal MICS incision where peripheral cannulation is being done, you put it in the same femoral vein and the femoral artery. Now, this should not be done. In a peripheral venous peripheral cannulation, the artery and the vein should be from the different legs, more for the ease of insertion as well as while taking it out.
And also to prevent compression of the artery.
Compression of the artery. The other thing is, if you are putting in a peripheral cannula, before inserting the antegrade of the peripheral cannula, you should think about distal perfusion. This is something which people have learnt over a period of time, where you have first cannulated the main femoral artery and you have started flows, and then you start searching for the vessel to put the cannula distally, but the vessel has collapsed and you do not find the vessel. So, whenever you are planning on a peripheral Ecmo cannulation for a arterial cannulation, first put the distal, take care of the distal cannulation first, which will take care of the peripheral cannulation, and then go for the main cannulation, so that it provides.
And you would definitely like to have echo guidance or ultrasound before hand of the vessel. Regarding complications, there could be complication with the laceration of the vessel, seroma, hemorrhage, and with the IJV cannulation, there is a possibility of pneumothorax also, I believe.
Exactly.
And
now, this has happened mainly in
for the
patients who are with bronchiectasis and those lung problems, and these are the patients who require them. And since the lungs are so bloated and they come on to the chest wall and into the central cavity line, a lot of times you may pierce the.
You were telling about the distal limb perfusion. How much flow is required to maintain the viability of the distal limb? That means not more than 100 ml per minute?
even that is
So
not
what would you
required.
put? You would put a
So there is a
6
5 French to 6 French sheath which is attached to the main cannula along with a
to the side arm.
to the side arm, the lure lock
Side
which is
lock,
present.
lure lock.
Now there are some that's one way of going through it. The other one is, if you want to prevent this, you attach a side arm or you attach a graft, a 8 mm or a 10 mm Dacron graft to the femoral artery and then pass the cannula. Then the circulation will be both ways in peripheral cannulation, but there you have to go for open method. You can't do it with a Seldinger method.
Yeah.
So that way you can avoid it. If you put a graft, the graft delivers antegradally as well as retrogradely. So the distal perfusion is taken care of.
So Dr. Nagesh, to sum up, I would call it that the cannulation choices have to be individualized.
Exactly.
And they are based upon the clinical situation and the urgency of the situation as well as the patient's criteria. With the availability of thin cannulas, central cannulation can be avoided and we can go on to the peripheral cannulation. We should plan it early with the availability of this combined cannulas.
The timing is most important.
And timing is also important.
Because as we were discussing earlier also, a lot of times patients say, no, how many patients have survived? We have put in so much, like you yourself said, and in our experience also, a lot of times we compare results. Ultimately, results will speak to about the procedure. So the timing of the institution of ECMO is important, as in any other surgical procedure.
So that means the decision has to be taken early, not afterwards,
Not
or
afterwards.
when it is too late.
And then you start blaming the ECMO.
Thank you, ladies and gentlemen.
Thank you.